Okay, hello. I'm Neil Mariados, a radiation oncologist at Associated Medical Professionals in Central New York, in Syracuse, New York. And I have been asked to give a small talk on the evolving intersection between inherited cancer genetics and therapeutic clinical trials in prostate cancer. And thank you for asking me to talk about this evolving and exciting topic. To get going, the family history of prostate cancer raises the risk of prostate cancer. And prostate cancer is associated with hereditary breast, ovarian cancers, and due to germline mutations in homologous DNA repair genes. This includes things like Lynch syndrome due to germline mutations. And 11% of prostate cancer patients have at least one other primary cancer that carry the germline mutations associated with this increased cancer risk. And this has implications of family genetic counseling, cancer risk syndromes, and assessment of personal risk for secondary cancers. So some of the testing recommendations look at family history and personal history of cancer, and this is becoming more relevant in the specialist domain. And this includes germline testing for patients with prostate cancers and any of the following risks, such as positive family history, high-risk prostate cancer, or very high-risk prostate cancer, or regional disease. In metastatic prostate cancer, this genetic testing is recommended regardless of family history, and in patients with Ashkenazi Jew ancestry or intraductal pathology. When we look at homologous DNA repair genes, these are somatic mutations in DNA repair pathways that occur in about 19% of localized prostate cancer and in 23% of metastatic castrate-resistant prostate cancer. And these tumors, 42% of these patients with metastatic castrate-resistant prostate cancers and with some with somatic mutation, BRCA2, were found to carry germline mutations, and 60% for patients with localized prostate cancer. About 12% of men with metastatic prostate cancer have germline mutations in one of the 16 repair genes, 6% mutation rate in high-risk prostate cancer, and about 2% rate in low to intermediate prostate cancer. These in germline BRCA1 and 2 have been associated with increased risk of prostate cancer, with a 2 to 6-fold increase in risk of prostate cancer with the BRCA2 mutation. And these patients that have this have prostate cancer that occur earlier in life, are usually more aggressive, and associated with significantly reduced survival than non-carriers. These germline variants are diagnosed at this younger age and have shorter median survivals and higher prostate cancer-specific mortality in men with positive family history. There was a Nordic twin study of cancer that showed that prostate cancer inheritability was estimated at 57%, which was higher than nearly all other cancer associations. The next thing we look at is DNA mismatch repair genes, and in these, mutations are seen in MLH1 to MSH6 and PMS2, and these result in a tumor microsatellite instability and deficient mismatch repair. And these are sometimes associated with germline mutations and Lynch. So starting with the basics, I think it's important for us to share a little background on the subject. We start with two working copies that could develop a damage, as we see in the top line. And this, if a second copy gets damaged, then tumor develops. In hereditary cancer, one damaged gene is inherited, so you already have one damaged copy in all cells. And this can be seen in breast and prostate cancer. And when you have these two damaged genes, then tumor develops. This is considered the two-hit hypothesis, or the Knudsen hypothesis, and this theory can attribute to people getting cancer, but also, more importantly, why people get cancer at an early age, because they're already one step further down that pathway. In cancer cells, there's no working copy of BRCA1 and 2, and Knudsen hypothesis is a two-hit hypothesis. So normal cells do have a working copy of the gene, so it can repair damage and survive. But in cancer cells, they do not have a working copy of DNA repair gene. Therefore, no repair occurs, leading to cell death. The DNA damaged cells keep accumulating this damage, and this leads to cell death. This brings us to PARP and PARP inhibitors, and PARP enzymes detect and initiate repair of single-stranded DNA breaks. And if these breaks are not repaired, the replication fork stalls and creates a double-stranded break, as seen in these cartoon figures. The double-strand breaks can be repaired by homologous recombination, which is BRCA dependent, and trap PARP collides with replication fork. It's the stalled fork that homologous replication needs to repair. And PARP trapping is the key cytotoxic lesion that PARPs induce as they block DNA replication. There is some evidence to suggest that PARP trapping is more important than enzyme inhibition, and not all PARP inhibitors have the same ability to trap PARP. But one of the drugs with the greatest trapping potency is talazoparib. PARP also slows down or inhibits ribosomes, and therefore the production of proteins that are needed for cancer growth. But you do not need to have PARP inhibition, do not necessarily need a BRCA mutation to be effective, and this can also be gleaned through biomarker tests. And PARP inhibitors are the leading in evolution in cancer treatment, and this becomes very important when we are testing for genetics, and this is another pictogram explaining this. And DNA repair pathways repair single-stranded breaks with PARP, as we see in the left side of this diagram, and double-stranded breaks with BRCA1 and 2. And the base excision repair is one of the repair pathways that mainly deal with PARP. Whereas in double-stranded breaks, homologous recombination repair occurs, repairing double-stranded breaks, referring to the BRCA pathway, so the cells survive. The body tends to use the BRCA pathway most commonly, and anytime there's a double-stranded break, it usually is a homologous repair. So over here in this scenario, cancer cells have to rely on the base excision repair pathway because the BRCA mutation is present and the survival mechanism for the cancer occurs. And the threshold of DNA damage is kept in check, and cells have to rely on the BRCA pathway, which is a survival mechanism. So we come to the next pictogram here. However, if both pathways are impaired, the PARP inhibitor and the BRCA1 or 2 mutation in homologous repair pathway, then the DNA damage accumulates and leads to cancer cell death. If both scenarios are present, the cell dies off. So cancer cells want to stay alive, but if both pathways are blocked, it dies. And this is called a synthetic fatality in PARP inhibitors. So now coming back to our story here. In regards to PARP inhibitors, this is a summary of the timeline. So in regards to PARP inhibition, this is a summary of the timeline illustrating development to approval. There's a landmark paper in 2005 written by Farmer in the Journal of Nature explaining and describing synthetic lethality in regards to PARP inhibition in BRCA cells. In 2009, a phase 1 proof of concept study of treatment with Olaparib in patients with multiple tumors, ovarian, breast, colorectal, and melanoma, was published in a population enriched for BRCA carriers. And this showed that Olaparib has anti-tumor activities in cancers associated with BRCA1 or 2 mutation. In 2010, a phase 2, another trial was published in advanced breast cancer, defining 2 cohorts showing significant response rate to PARP. Now, in 2014, a landmark paper showed that ovarian cancer patients with BRCA mutation who had already received 3 or more chemotherapy treatments showed impressive positive results with the use of PARP agents, and the first PARP FDA was approved. In 2017, which is not shown over here, but Olaparib maintenance therapy was approved in relapsed patients with platinum-sensitive BRCA mutation in ovarian cancer. In 2018, there was Olaparib approved for BRCA mutated metastatic breast cancer. So this is a lot of accomplishments over this length of time. And this is one of the initial studies showing the Moore study in ovarian cancer and demonstrating improved outcome in ovarian cancer with olaparib. Olaparib, or placebo maintenance, was assigned in a 2-to-1 ratio in 391 patients and with newly diagnosed ovarian cancer who had complete response or partial response after platinum-based chemotherapy. And these findings are significant compared to other studies like these, showing a risk of disease progression or death was 70% lower with olaparib, 60% versus 27% with a hazard ratio of 0.3. In 2017, Robson in the New England Journal publication was yet another study demonstrating effect with olaparib and was approved for metastatic breast cancer. This showed survival curves demonstrating that olaparib has a superior progression-free survival to standard therapy in patients with metastatic breast cancer who have germline mutations, showing a 42% reduction in risk of death, demonstrating again that PARP is tumor agnostic across multiple tumor types, and targeting, and this was basically because of targeting the BRCA mutation rather than a specific tumor type. These are the survival curves in metastatic breast cancer demonstrating that patients naive to chemotherapy had improved overall survival of 7.9 months with PARP. Again, these are all on their way to showing some relevance to our topic of prostate cancer. But then this is a recent paper showing that this is pending approval for pancreatic cancer that was in the ASCO in June, that was presented and was significant for metastatic pancreatic cancer, and the FDA should approve the drug fairly soon for this site as well. But the field is continually expanding with the development of new drugs, and there are ongoing trials to determine effectiveness of PARP inhibitors in other cancers, including pancreatic, mainly advanced, recurrent, and platinum-sensitive pancreatic tumors, and looking at different types of mutations, PALB2 or other gene mutations, and some trials include all patients. This is going through some of the PARP inhibitors over here. None of the others are approved, only olaparib approved for pancreatic cancer. So the completed PARP, to get to the prostate cancer, you can see the evolution that has gone through to get to this topic. But the completed PARP trials in clinical trials results in prostate cancer. The large trial here, phase 1, but included 3 patients with prostate cancer. But the paper was mainly about breast and ovarian. And this was some inkling into delving into the prostate cancer world. But one patient had metastatic disease and a germline BRCA2 mutation. The patient experienced a 50% reduction in PSA level and continued durability for 3 years despite metastatic disease. And this was published by Fong in New England Journal in 2009. Then we get to, this is another completed trial in prostate cancer. It's a phase 2. It had 8 patients with metastatic castrate-resistant prostate cancer. 7 had BRCA2 mutations. 50% partial tumor response rate seen in this patient, with a median progression-free survival of 7.2 months and a median overall survival of 18.4 months. This was a paper with Kaufman in Clinical Oncology in 2015. When we get to the TOPARP-A trial, this is a completed phase 2 trial, which focused on metastatic CRPC patients with DNA repair defects. And this is a larger study with more prostate cancer patients. And this was, Mateo had published this in New England Journal in 2015, not just for BRCA1 and 2, but basically there were 49 men evaluated, 16 men with metastatic CRPC. 16 of them had a response. 16 patients had a DNA repair gene mutation, and significantly longer radiologic progression-free survival was seen in these men, 9.8 versus 2.7, with an extremely significant. p-value. There's an increase in overall survival, the median of 13.8 months versus 7.5 months with patients with mutation, and 7 men carried a BRCA2 mutation and responded to olaparib with a 50% reduction in PSA level. This marked 4 of 5 patients with ATM mutation responded. So this is not a clinical trial, but a case series where 8 men seen with metastatic CRPC and a DNA repair pathway defect. Greater than 50% reduction in PSA was seen. 4 patients had a germline mutation in BRCA. All 4 patients had a significant response to PARP. 60 to 100% PSA reduction was seen. And the patients with 100% PSA reduction were still on the drug at week 78 with complete remission. The other 3 patients had significant responses for 20 to 32 weeks on drug, and the patients without BRCA2 mutations had no response to PARP inhibition and are all deceased, showing just the marked responses that these patients had. This is from the European Journal of Urology, evaluated 22 patients with germline mutations, and this demonstrated the importance of exploring these avenues to further understand their interrelationships. There are many open trials for prostate cancer, and you can go to clinicaltrials.gov to see all these trials that are both national and international. But I thought that I would just highlight a few of these, and this one is analyzing the outcomes of patients with rare mutations in the UK with BRCA1 and 2 and HOXB, and comparing the carriers and the non-carriers. Another one called the PROREPAIR-B in metastatic CRPC, evaluating the impact of aberrations in DNA repair, and it's a completed Spanish study. It's non-interventional. But here are some other trials that I thought that I'd pick up over the 119 genetic mutation trials that are current. I've picked a few over here at the Barcode 2 study, and this is still recruiting in the UK, and this is use of a genetic profile to guide prostate cancer treatment. There's another French study that's recruiting that is looking at the homologous recombination pathway that's evaluating the efficacy of carboplatin in metastatic CRPC with gene alterations. There's a multi-institutional US study that is recruiting, is treating with carboplatin or docetaxel and BRCA deficient prostate cancer. And the Moffitt is another multi-institutional US study that's still recruiting, looking at immunotherapy in metastatic prostate cancer, and others looking at CDK12 mutations. So there's a lot of these going on. You can go to clinicaltrials.gov to access that. And here are some of the PARP trials in the UK, in Chicago, UC Davis, Brazil, international multi-institutional studies looking at olaparib and degarelix, PARP inhibitors, and Temodar, the TRAP trial, and olaparib at the Fred Hutchinson, used before surgery in localized prostate cancer. So it is a very exciting area of research that is going on currently all over the world. In BRCA1 and 2 and platinum-based chemotherapy, how does this work? In platinum-based chemotherapy, it causes DNA damage that can only be repaired by the homologous recombination repair pathway, use BRCA1 or 2. In cells that lack BRCA1 or 2 activity, this platinum-based chemotherapy exploits the fact that the major DNA repair pathway is defective. It's similar to PARP inhibitors, that this accumulation of unrepairable DNA damage leads to cell death. In prostate cancer and chemotherapy use, it's in metastatic prostate cancer. Chemotherapy is a standard current option once a tumor has become castrate resistant. We know that tumors with BRCA2 mutation carriers are more sensitive to platinum chemotherapy. If you're going to have chemotherapy used, these patients can ideally fast track to platinum chemotherapy. Typical chemotherapy begins with taxanes. We try to get them to platinum or carboplatin. However, in patients with BRCA1 and BRCA2 or certain other DNA repair genes, platinum-based chemotherapy could be used sooner, as outlined in the NCCN guidelines. Here is some studies further showing this evidence for increased sensitivity to platinum. Chang showed this in the European Journal of Urology, and here's another one in Cancer by Pomerantz, published in 2017, showing the association between germline BRCA2 variants and sensitivity to platinum-based chemotherapy among men with metastatic prostate cancer. And over here, the conclusions show that the BRCA2-associated CRPC patients is associated with a higher likelihood of response to carbo chemotherapy than non-BRCA2-associated prostate cancer. In regards to another group of drugs, the PD-1 inhibitors, this is a paper that illustrates targeting with PD-1 inhibitors in patients with DNA mismatch repair, showing a group that is particularly sensitive to checkpoint inhibition. This led to the approval of PD-1 inhibitor, pembrolizumab, for solid tumors with mismatch repair deficiency, possibly in Lynch patients. And in this, it showed that it is a 17% response rate in unselected patients. So pembrolizumab, or Keytruda, is a PD-1 checkpoint inhibitor, FDA approved for patients with solid tumors, including colorectal and prostate, who demonstrate deficiencies in the mismatch repair pathway. This included microsatellite instability, MSI, or germline or somatic mutations in a mismatch repair gene. So in summary, tumors in patients with BRCA1 and 2 mutations may be highly susceptible to PARP inhibitors and platinum-based chemotherapy, and tumors in patients with mismatch repair gene mutations may be highly susceptible to immunologics, and information about a metastatic CRPC patient mutation status is now essential in guiding treatment options. And this hopefully has shed some light in the exciting research that's going on in this evolving intersection between inherited cancer genetics and clinical trials in prostate cancer, and hope this was helpful to you in understanding this space. Thank you.